Hello. All right, so we thank you again, everybody, for joining us today, and welcome to our final session. And we're definitely in for a treat. So we've invited back Dr. Stephen Berns for our plenary session, What Matters Most, Person-Centered Goals of Care discussion for cancer patients. And he's also joined by Dr. Ben Clement as well. So I'm going to introduce them both. Dr. Berns is currently an associate professor at the University of Vermont. He's a graduate of Brandeis University and also attended medical school at the Icahn School of Medicine at Mount Sinai. He completed his training in internal medicine and fellowship in hospice and palliative care at Mount Sinai Hospital, and over the past 10 years has worked as a palliative care physician, seeing patients in both the inpatient and outpatient settings. He served on local and national committees, helping to improve palliative care education for students, residents, fellows, and practicing clinicians, and has been involved in serious illness communication skills for the past 12 years nationally. He is joined by Dr. Ben Clement, who's with Colchester Family Practice, but has also worked on the UVM hospital service. Both of them locally teach with Talk Vermont. So Dr. Berns is the director, but both are part of Talk Vermont, which is a multi-component intervention to improve the frequency and quality of serious illness conversations among clinicians across the UVM health network. So to date, Talk Vermont has had over 400 practicing clinicians, and I'm a proud graduate of that program, and it's fantastic, and 500 trainees in serious illness conversations, and 400 clinicians and 500 trainees in serious illness conversations. So we're so happy to have both of you here, and I'll turn it over.
I feel like we get the honor of closing the session, so I don't know if that makes me extra nervous on the stage, but really appreciate and honor to be here today to really talk about one of my favorite topics, or both of our favorite topics, which is finding out what matters most to patients. And we just want to mention that both of us are Talk Vermont coaches, without significant financial relations, but we will talk about some of the material here is what we teach our clinicians, and we wanted to share with you some of the pearls that we teach on a regular basis. So over the next 45 minutes, we really want you all to get a sense of what do serious illness conversations look like, recognizing the potential for goals of care conversations for cancer patients, discuss the difference between treatment-centered conversations and goal-centered conversations. If there's one objective that we want you to take away, it is that one. Recognize the importance of listening goals and values, and then we'll give you some tools to think through those, how to ask about goals and values. And one of the mnemonics we'll teach you is called the values mnemonic. But before we talk about medicine, we want to start with an analogy. So let's pretend you are leaving this conference and you are driving back home and your car stops working. And you are now on the side of the road and asking for help. Fortunately, you have really good insurance. AAA comes by, they bring your car over, and the auto repair person is looking at your car. And they say, what do you want us to do? Do you want us to fix the lube coolant link level? What about the faulty catalytic converter? What about the clogged camshaft? Or the cracked head gasket? Or the leaky airflow sensor? Or these loose spark plugs? Or your burnt out radiator? So I just want you to think for a moment, how would you feel when they asked all these questions? How do you feel? I hear overwhelmed. Any other feelings? Sell the car. You're just noticing there's lots of things wrong with this car and you're like, just get rid of this thing. Anything else? Anxious, annoyed, fear. Can I ask, why are you annoyed? It's the person who said annoyed. Yeah, They should know, not me. I'm going to convert this to medicine for a moment. So let's say now you or a loved one, super sick, and they ask the same question. What do you want us to do? Would you want us to start some vancomycin or tube feeds or dialysis or tracheostomy or blood transfusions or wound debridement or go to an LTAC facility? And that same overwhelming feeling could feel like a menu for our patients and their loved ones. And my favorite is sometimes we do this hospital menu and we say, would you want us to do everything possible? Or would you want to be as comfortable as possible? I remember one of my first palliative care meetings when I witnessed, and the woman who we're asking this question to said, well, can I have both? And it made me realize that it's not really the treatments that are important. It's how someone lives their lives. What will the treatments accomplish? What are the outcomes that someone wants to achieve? So we're going to keep this theme in the back of our heads for a moment. And I want to share a video perspective of exactly this. And this is actually from a patient, Talene, and I'm going to share with her, if I can get it. Yes. And I'm going to rewind this so that it's playing from the top.
I want to live. I think I said something like I want to live, but I don't want to be sick all the time trying to live.
Clinicians think it's going to take too long to talk about values because they think, oh, I'm going to have to step back. We're going to have this really long conversation. But, as Talene shows, asking people about what's really important can get people right to the point.
I want them, if they didn't understand kind of who I am, I want them to ask me about that. So what are you doing right now? What's your life like, and what do you enjoy doing? What do you look forward to doing? And it's to get a kind of sense of the kind of person I am, because for each person, I think it's so different. And I have a list of artists that I want to hear at least once. So I'm kind of working down that list. So back in March, for instance, I went to see Bruce Springsteen. My friends were impressed and surprised to hear I was there. In fact, a couple of my younger colleagues saw me there and said, Pauline, you're at the Springsteen concert. I said, of course. I want to live. I think I said something like I want to live, but I don't want to be sick all the time trying to live.
And that video is from Vital Talk, which a lot of the materials that we work with is based off of, and from Tony Bach's work at University of Washington. So I'm going to talk about serious illness conversations, and we'll get back to this idea of really hearing patient stories. So let's talk about why are serious illness conversations important for patients living with cancer. Well, first, I want to start with the definition. And this is what Ariadne Labs out of Harvard defines a serious illness conversation. They say it is a compassionate, clear conversation about patients' priorities, values, and goals. And I just want to highlight a couple words here. First, clear, that there's clear understanding of what is going on with the cancer. Two, that it's really focusing on those priorities and goals. And three, that there's some heart in there, some compassion. And we know from several studies that early conversations about patients' goals and values relate to better serious illness care. For example, they increase goal concordant care, meaning what patients desire and how they want to live. If we have these conversations early and often, we will achieve that goal in the end. It improves quality of life and patients' well-being. So several studies have shown that having these conversations, and you actually follow patients over with quality of life surveys, you can actually notice an improvement. It does result in fewer hospitalizations or fewer access to the ED for patients that it's important to be with their families and not in spending their time in the hospital. That does match that. It does create early and more often referrals to hospice. And finally, several studies have shown that it helps families cope better with the illness. And a lot of clinicians agree. 98% say I should be having these goals of care conversations on a regular basis. But unfortunately, only 14% say they actually do it. So why? Why are clinicians not engaging in these conversations regularly? You can shout them out. Time is usually number 1, 2, and 3. What else? They don't know how to. Yeah, many are not trained in this. What else? That's right. So they may not know exactly what the options are available if things aren't working how we planned. Any other reasons? It is uncomfortable, particularly around emotion. And cultural, right? Is this something that my patient wants to talk about? Is it something that's within their culture to talk about it? Any others? Name some really good ones. So actually, we did a Vermont study, a hospice study in 2016. At the same time, the Cambia Health Foundation did a similar study and found out these barriers. 1, not enough time. But believe it or not, these conversations, if trained well, take 18 minutes. 2, it's someone else's role. So if the primary care clinician's like, well, it should be the oncologist's role. And the oncologist is saying, well, maybe it's the primary care's relationship role because they have more rapport. Or they're in the hospital and the hospitalist says, no, it should be the oncologist who's in the outpatient setting. All of a sudden, we don't know who's actually responsible for the conversation. It provokes emotion, and people are afraid of provoking emotion and knowing not what to do with it. Some just don't feel like they have the tools to prognosticate. And others are like, they came to me to treat disease. Why would I have this conversation when maybe I have to say, I don't have anything left? Unsure what to say and how to respond to things, and no formal training. So you named a bunch of those. And one in the pediatric literature that's not here is taking away hope, or fear of taking away hope. Even if you say, I worry this might happen. The last other one is afraid to talk about it. But we know that actually patients do want us to bring it up. And 95% of patients want us to bring it up so they know what's going on. And the other 5%, it's not that they don't want to hear it, or they're the ones who don't want to hear it, but they want you to tell a loved one. So most patients want us to tell them. What's interesting is when these conversations are done, they're often done too infrequent. And there's one study that showed 1/3 of patients with end-stage diagnoses had discussions with their clinicians. These were people guaranteed to die from their illness, and only 1/3 had conversations, according to the patients. They're often done too late. There was a couple of studies in the cancer population that showed the first time this conversation happened was 33 days before they died. And the last one, which Ben and I are going to concentrate on for most of today, is that the conversations are limited and they're focused on treatment decisions and not on goals and values. We'll talk about the problem with that. So I'm going to share some cases, and these are true cases from my journey as a palliative care physician. The names have been changed, and I actually named the 2 cases after my aunt's dogs just because she showed me a picture of them and they're lovely names. So bear with me. So this is the first case is Claire. So Claire is a 70-year-old with no past medical history. She went to the primary care clinician with her spouse And the clinician actually said, let's talk about goals and values. And so they had a conversation about life-sustaining treatments. Would you want to be resuscitated? Would you want to be on a, if you were ever going to get sick, would you want to be put on life support? And she says to the clinician, I have a lot to live for. I want everything done to keep me alive. Makes sense. She completes a COLST and chooses the resuscitation and intubation options. And for those that are not familiar with COLST, it is one of the documents that say the kinds of treatments you would want if you were seriously ill. The next week, she unfortunately has a severe change in her clinical status. She suffers a massive heart attack. And during the process, when she's in the ICU, they found that she has metastatic cancer of an unknown primary. They're not sure where that source is, but she's too sick for them to figure out why. She's currently on a breathing machine to keep her alive. She's sedated. She is now requiring dialysis because she got super hit with low blood pressure. And the team fears that she's never going to get out of the hospital or even wake up. But the family insists that they follow her wishes to do everything to keep her alive, because that's what she said a week ago. So I'm going to ask the question, do you continue keeping her alive according to her COLST? 2, remove the life support because you see she is suffering. Or 3, explain to the family that she is in a different place than she was before. And that's a metaphorical place, not a physical place, although she is in a different physical place. Oh, there's no legal issues here. Nope, just presenting. I mean, show of hands, how many would pick 1? Right? Few people picking 1. How many would pick 2? How many would pick 3? Well, at least you all are a great audience. So interesting enough, this family had a hard time because they wanted to follow her wishes to the T. And so what is this case illustrating? What was the problem with the goals that she made a week prior? Yeah. Yes. She made it based off of knowing she was perfectly healthy. So lesson 1, context is important to asking about goals. People might choose very different things if they don't know what's going on with them. And so really thinking about making sure that everyone's on the same page about what's an understanding of the illness before you move forward, because if we knew that she had metastatic cancer and then said what's important to you, that may be a different answer. Maybe. Great. Case 2. So Lily is newly diagnosed with pancreatic cancer. She's 77 years old. She's planned for a Whipple procedure. And during the procedure, she ends up having a serious event, and she has a left facial droop. She has a CT scan that shows a massive stroke, and she's intubated and sent to the ICU. So another ICU case. Fortunately, she had a living will that was completed in the last year. And she said she would want CPR, she would want a trial of intubation, she would want antibiotics, she would want a trial of artificial feeding, and she would want IV fluids. That's what she said in her living will. It's now 2 weeks later, and nothing has changed. Do you, 1, keep her intubated and continue her with the artificial feeding and plan for moving this is a little more too medical, but moving the ventilator to more of a permanent way through a tracheostomy in a feeding tube, and give her transfusions, dialysis if she needs. 2, keep her intubated with artificial feeding, but when the time comes for a trach, we work with the family to say, you know what, moving to a trach doesn't sound like that's a trial, so let's keep her comfortable and take her off life support. But we'll give the transfusions, the dialysis until the point. And the last one is determine that the trial is over and focus on comfort, and do not add transfusion or dialysis ever because it is not included in the living well. Is there an option 4? So, multiple choice. Raise your hand if you would choose 1. 1 is continue everything, move her to trach, and continue the life support because it doesn't seem like the trial is over. No one picked 1. Okay. How about 2? That this is now the time where we can say, trial is probably over. So a few folks. And then 3, the trial is over and let's take her off life support. This one is a way more split votes than the previous one. So it sounds like 2 and 3 were definitely heavily. And as a palliative care person, I have no idea what the answer is here. So just to let you know, what I will say is I have no idea what a trial is, and it's not defined in a living will. So what's the problem with this case when it comes to goals of care? Yeah, there's not a lot of like specifics about who she is. What else? Only one option involves the family, which is really good, like including family so they can be her voice. Yep. The other thing that this illustrates is this living will spends too much time on treatments, which treatments cannot extrapolate to everything we do in a hospital or to a discharge plan or to anything else. So, asking about how patients want to live their lives benefits both patients and their clinicians. For the patients, questions are easier to answer. If I asked a patient what's important to them versus, would you want us to resuscitate you? Someone has a much easier time saying, well, here's the important things in my life. 2, stressing them to give a choice can be burdensome. And a lot of families, when they are making choices about life support, feel stressed and anxious because they worry they're going to make the wrong decision. But when they're asked what is important to their loved ones, they know that answer mostly, and they don't feel as conflicted. It also builds trust and rapport with healthcare teams when we get to know someone and get to know what's important to them. And for clinicians, this is much easier for us because we get to know a patient and we can build trust and rapport ourselves. We can extrapolate how someone wants to live the life to treatments we can offer. And finally, for me, it increases the meaning behind the work. If I get to know that I'm going to help this patient live to their granddaughter's graduation, that gives meaning for me. So Ben's going to tell us about a framework for you to consider.
Thanks, Steve. So again, my name is Ben Clements. I'm getting a spam phone call right now. I'll turn that off. I'm a primary care doctor, a family doctor, and again, I work in both Colchester Family Practice and in the hospital across the street as a hospitalist doing general adult medicine. And this kind of work is what brings really importance and meaning to every day where I'm in the hospital. So thanks to Steve for bringing me in on this. So we're going to talk about a framework called I-PREMAP, and this comes to us from Ariadne Labs and from Vital Talk. And Steve and some other colleagues have helped bring this to Vermont, and we've tailored it a little bit to our needs. It's going to start, well, before I get into this, we spend a day or two in Talk Vermont teaching all of these skills and practicing and drilling and helping people get really good at it. I'm going to spend about 20 minutes going over all the same stuff. So we're going to race through, but I think it should give a good introduction to what we hope clinicians can achieve. So for the I-PREMAP model, we're going to start by introducing the conversation. Here we're setting the stage, we're normalizing these conversations. I often say that every one of my patients who I'm helping treat a serious illness, I want to have one of these conversations so I know where we're going. The next step, it's important to prognosticate and lay out the big picture in simple language so that both you and the patient understand what's ahead. And we'll talk more about that in a few minutes. Of course, whenever we're giving big news like a diagnosis and a prognosis, we have to expect there's going to be heavy emotion that follows that. In our larger courses, we talk about how we can handle that emotion and respond to it. But the important thing to recognize is that whenever people are facing really hard, difficult emotion, their prefrontal cortex is hijacked, and it's hard to process the cognitive bits of this. So we have to really acknowledge that emotion before we move forward into anything cognitive. Where I want to spend most of our time is mapping out values, and this is clearly making a path for what's important to the patient. Then we align and propose a plan. I think many of us in practice jump right from prognostication to plan. And this is part of our medical school education. We're taught through multiple choice tests that the next step in the treatment pathway is this. We're not really taught to step back and think about what's important to the patient, and that may change what the next best choice is. So let's talk about prognostication. Let's go back to the car analogy. My car is actually in the shop today, so I was thinking about this stuff pretty heavily. So fortunately, we get AAA to bring us to the auto body repair shop, and the mechanic says there are so many things wrong with your car that if you keep driving this way, you'll have a serious accident. How is that different than the scenario that Steve posed? I'm asking that out to the group. Yeah, it reflects things back to the client in this case. Great. What else? Yeah, and what I see here is this is a really clear summary. Besides that list of the 15 different things that are wrong with the car, I don't know what any of that stuff means, but I do know what a serious accident is, and I want to avoid that. So having that clear headline is really helpful for me to make a choice. Get through all this. So we can take this into the hospital, and we can take a headline, which we in Talk Vermont describe as a summary of the medical information and a summary of what that means to the patient. So in the hospital, a headline would look like this. Your family member has severe organ damage from COVID, and we're worried that your loved one could die. So we've got the medical information plus the meaning. What do you want us to do? Get through all this stuff here. So why is sharing prognosis important? And to us, it provides context for the medical decision-making. So giving that one statement back here is much different than saying your family member has COVID. What do we do? It helps patients reprioritize their goals, and it helps patients and their loved ones prepare for the future. Next, let's jump to mapping out values. So back to our car mechanic. Instead of asking the question that I ended with of what do you want us to do, how might the mechanic get to our values? So one of the things that I like to think about with this analogy is I know very little about cars. Most of them have 4 wheels, there's a steering wheel, and they get me where I need to go. I'm not an expert in cars, but I am an expert in what I need to do with my car. And same thing in the hospital. I think many patients are not an expert in medicine, but many clinicians are. And they're not an expert in what the patient values. And so what we're trying to do here is create a team that unites those two things, the expert in the medical decisions and the expert in the patient's values, and bring them together to make a plan. So in doing so, we're going to focus on this mnemonic called values. And V stands for vital goals. And a question that might get to vital goals is, knowing this news, what's most important to you? A stands for activities. When thinking about the future, what would you want to be doing? L stands for limits. What would be an unacceptable quality of life or a life worse than death? U stands for uncertainties or worries. When thinking about the future, what worries you? Experience with illness is E. How was the last time you were in the hospital? Would you do anything differently? Has anyone in your life been seriously ill or even died? And how does that affect your decisions with your healthcare? And finally, S stands for strength and support. What gives you strength as you think about the future with your illness? And I want to highlight that there's context with each of these questions. So there's a difference between what's most important to you and knowing this news about your illness, what's most important to you. There's a difference about when thinking about the future, what would you like to be doing and what kind of activities do you like to do? This also changes when we're working with a surrogate, a family member, or a healthcare agent. The questions can be posed in a different way to get the same context. So there's a difference between, let's go to the second one here. What worries you? If that's proposed to a family member, they might say, I'm really worried my mom's going to die. But the question, if she could tell us what would your mom worry about, is going to get us a very different answer that's going to help create a different plan. And finally, we like to ask this question, what else? So as we chip away at all those values, asking what else after each one usually gets us more information. The stuff that's most important to the patients are usually not the first thing they say. It takes a little bit of probing to get to the good stuff at the bottom of the well. So how do you know when you're done with mapping? Usually patients and families just can't think of anything else. They'll tell you, that's it. Or they start repeating goals and values over and over. And so asking a range of these questions to get to different categories will help us create or gather enough information to create a good plan that's patient-centered. And we recommend that you ask at least one question from 3 different categories with a couple what else's in there. And finally, let's get to proposing a plan that matches goals. So if my mechanic, which didn't happen this morning, but I think he's a very good mechanic. If my mechanic asked me questions about what do I need my car to do, I might say something like, I only needed to get back and forth to work. It's a 10-mile round trip. That's all I really need to do. I don't want to spend more than $1,000 on this car. It's pretty old. I don't want to invest a lot of money, but it's got to be safe because I've got young kids and we have to get back and forth to school. They might make some different recommendations than listing changing spark plugs and fixing the coolant and all that. I'm not a specialist or an expert in being a mechanic, as I've said, but now with this information, the mechanic can create the plan that works for me. So in discussing steps to making a recommendation, we're going to start by asking permission. That might look like, thank you for sharing that with me. I'd like to reflect together on what you've shared and make a plan for moving forward. Would that be okay? And then proposing a plan that shows that you've been listening to all those values. We kind of skipped this, but aligning is the aligning step in REMAP is a great chance to describe that or show that you've been listening, summarize what the patient's goals are, and make sure that your plan reflects what they've been interested in. That would look like, based on what you've shared with me, given where things are at medically, I would recommend, and then there's a list. Finally, checking in. How does that sound to make sure that the plan that you've proposed aligns with what they hope to achieve? There's a couple different types of recommendations. There can be treatment-focused recommendations. This one's focused on a referral to an integrative pain clinic. There can be communication-based recommendations. So we're inviting a healthcare agent to come into the next conversation so that they can learn what the goals and values are. And then we can get really focused down on to things like resuscitation and end-of-life plans. And this one, I think, is written pretty well. Because you told me that thinking and acting for yourself are really important, that you would never want to be a vegetable, I recommend that if you are ever at a point in your illness where you're no longer able to be independent, that we allow you to die naturally, focus on your comfort and dignity, and not perform CPR. Okay. So let's shift gears a little bit. Who should we involve in these serious illness conversations? As a busy clinician, I can't have these conversations with everyone at every time, and sometimes they don't make sense. So I'm going to put up some cards here, and we'll read through them. And I'd like the audience to think about who they would prioritize for a serious illness conversation and why. So first is Professor Plum. She's 80 years old and has coronary artery disease and newly diagnosed DCIS of the right breast. Next is Mrs. White. She's 70 years old and has colon cancer, status post-surgery and adjuvant chemotherapy, now in remission. Colonel Mustard is 56 years old and has stage 3 breast cancer and peripheral neuropathy secondary to chemotherapy. And Mr. Body is a 35-year-old, Miss Body, sorry, is a 35-year-old with no significant medical history who is a professional skydiving instructor. Mrs. Green is a 38-year-old with AML planned for bone marrow transplant. And finally, Miss Scarlett is a 66-year-old with newly diagnosed small cell lung cancer with metastasis to the brain. Okay, so volunteers from the audience, who stands out to you as someone you'd prioritize? This is my mechanic calling me right now, actually. We'll get back to him. Miss Scarlett, can I ask why? So she's got some serious illness with metastatic disease to the brain. Great. Who else stands out? I'm sorry, I didn't hear you back there. Mrs. Green, why is that? Okay, great. Another serious illness. Fantastic. Is there anyone you wouldn't prioritize? Even though there's a very high-risk profession there? So I'm hearing Mrs. Body would not be prioritized. Anybody else? Professor Plum? Yeah, that was one that I'm kind of on the fence about. Tell me what you think. Exactly. And that's why I'm kind of stuck with that one. It creates for good conversation. Oh, I heard 50% of the time DCIS doesn't manifest in full-blown breast cancer. So there's a microphone going around also. All right. I think that's enough. So I think the summary here is people with serious illness. Well, let's go to the summary slide here. We should consider patients with life-limiting illnesses such as advanced cancer or end-stage organ disease, patients with chronic medical illnesses that impact their daily function or quality of life, and patients with frailty or declining function. And we're also taught to ask ourselves this surprise question. Would you be surprised if the patient in front of you has a serious event or even dies within the next year? Everybody else, at least in my primary care office, I try and get a healthcare agent form nailed down so we know who we're communicating with. And I hope that I can guide them to have some conversations about their goals and values. Great. In terms of when, we'd like to time these conversations away from the crisis. Right before someone gets intubated is not a good time to ask if someone wants that. A good time would be in transitions of care settings, usually as we're de-escalating. So Dr. King over there works in the Milton Family Practice office, and we've built a hospital discharge clinic. So one day there's one provider seeing everybody from that office who's been discharged from the hospital. This is a great time to have that conversation. What was the hospitalization like? How did that change your approach to your illness? That's another good time when there's a new diagnosis or when there's a progression of an existing diagnosis. It's also good if someone wants to have the conversation. I think that's all we have.
So we'll take a quick Q&A and then we'll leave with a little bit. But I think the thing we want to sort of emphasize here, if we put all those together, is that the medical world, they're the experts in the medicine, just like the car mechanic. They know what treatments could accomplish, what treatments may not accomplish things, but they are not the experts in the patient. And so the patient's goal is to share their goals and values, knowing what's going on, or the family to speak about their goals and values. And my colleague over in Tacoma, Washington, he calls this the house model. One side of the house is the medical information and what is possible. The other side of the house is the goals and values and culture and beliefs. And they come together to form the roof, which is the shared decision. And that's where we want everyone to think about how they exchange those ideas to come up with the shared decision. And the floor of the house, or the foundation, is the rapport and the relationship that they have together. So I want to stop there and see what questions do you have about this? And we'll make sure also the folks in the chat can ask away.
So nice talk. Thank you very much, both of you. I wanted to ask you how you handle a difficult scenario. The patient who you've had a goals of care discussion with, you're comfortable with what the goals of care are, the patient's intubated in the ICU, and the son and daughter who live in California arrive to the hospital, and of course are not at all in alignment with what the patient and you had discussed, and they're the medical proxies.
So funny because in California, so my grandfather is ill in California, and those doctors always say the son and daughter from New York. So just to think about that. So do you want to answer? Do you want me to answer? Okay. So that is not an uncommon scenario. What I find is we all know that the people who are living closer to the person who's seriously ill usually are on a closer page than those that are living far away. And there's many reasons for that, and we cannot change family dynamics in the moment, but often the families who live far away are not as clued in. So we'll talk about preventing, and then we'll talk about what you do if you haven't prevented. Preventing. Really important in the beginning, as you're building sort of trust with your clinician, if you're a patient, or with your patient, is make sure who needs to be involved in these conversations is present. So sometimes in the outpatient world, I'll say, hey, we're going to talk about what's going on next week. Who in your family should be involved? But also getting to know how the family gives information out. And so sometimes also like, who's the spokesperson to let the family know? So that's one piece. And then making sure that you have these conversations frequent and often, if you can do that. So that's thinking about the prevention. Sometimes though, things happen really fast or unexpectedly, and here you are. So then what to do there? So if a family member has not witnessed the conversation, that is really tough. And I, as a clinician, know that my patient is first, but their loved ones will continue to live with whatever decisions we make. So it becomes complicated because we want to honor autonomy, but we also want to preserve the love of this family. So it is a delicate balance. And how do you introduce patients' goals and wishes? And so often what I find sometimes is we get stuck in the treatment. So I would say they decided to go do X, Y, and Z. They decide to get further chemo. They decide not to get further chemo. But what's really important is figuring out the rationale of why someone decided that, and in getting them to explain that out loud, to share that back with their family, because often the families would be like, oh, they decided that because of this thing. So your mom shared with me that she didn't want further chemo because she is feeling so much pain and she cannot go to play bingo every night. And bingo is really important to her. And so often the family and their loved ones would say, you're right, bingo is very important, hopefully if they know her well enough. And so sometimes anchoring on those values can get people up to speed. The second piece is I also know that whenever a new entity enters, we do backslide a little bit with conversations. And for me as a clinician to be a little forgiving, that I'm going to have to backslide and sort of do these conversations over again. Another technique that I will do if a patient can no longer speak for themselves, I actually will say, if she were sitting right there, what would she say? And that really also is helpful in that. So I hope it's a couple of things. I'm not sure if they're perfect, but a couple of things.
Thank you for a great talk. From one of the viewers online, I'm a health. Can you hear me now? Okay. Thank you for a great talk. Well, from one of the people online, I'm a health practitioner out of state. Do you offer online training in values mapping or I-PREMAP?
Yes. So there is online training. So if anyone's interested, couple of things. If you belong to a health network that has access to the Center for Advancing Palliative Care, or CAPC, they actually have online modules that you could actually use. Vital Talk, also we mentioned, which a lot of the curriculum has an online module and also has like a phone app that has tips that you can sort of read through and go through there. And also our Talk Vermont does provide virtual learning as well. So there's lots of different places out there for that. I think most people, as soon as the pandemic happened, everyone learned how to teach virtually, which is lovely.
I have a related, not ethical question touching on your presentation, but rather a real world question. And that is, what is the role of public and private health insurers in approving or authorizing end-of-life care decisions for the hospital or hospice patient? Thank you.
Not sure if I will answer that well enough. I guess maybe I'll have a follow-up question. What is something you're wondering about? Maybe that'll help me. Is there something you're worried about or wondering about that would be helpful?
To put it bluntly, are Medicare, Medicaid, private insurance companies, Medicare Advantage, are they supportive of quote unquote heroic measures to keep the patient alive indefinitely?
Yeah, that's a really great question. So what I would certainly say is in our current health system versus others, I would say, at least from my work and my perspective, I have never really gotten a knock on the door or a metaphorical knock on the door from insurers saying, stop what you're doing. It's not making any sense. I think insurers really value patients' choices. With that said, I will say that insurers do cover end-of-life care and hospice care. And oftentimes people are worried about that switch. And sometimes they're like, I'm not sure if my insurer will pay for hospice, but they do. There are some nebulous sort of middle grounds where insurance might say, hey, why are you choosing this antibiotic or other things where people meddle? But I would say 99% of the time, most of the time, if we say, this is what the patient told us, this is what was documented, they say, okay. Now we can talk about the ethical parts of that, but I would certainly say, I think we are fortunate to live in a system that really takes patients' choices into account, with rare exceptions.
Yeah, I agree. Thanks for opening up some great topics for thought. I'm wondering if in the future there are plans for perhaps extending these conversations, not necessarily with patients who are seriously ill, but patients who are trying to weed through the details of an advanced directive to answer some of these questions, prompt some of these thought processes, not to wait until you're in crisis or wait till you're really ill and you have to start making those decisions.
I think that's really lovely. And do you want to, did you want to answer that one, or do you want to? Yeah, I know as a primary care clinician, this is really up Ben's sleeve.
Can you repeat that one more time concisely? I think we're ready.
I'm wondering if there are plans or if it would be beneficial to put something out there for the general public, or when you're working with your patients who are not seriously ill, are not in a crisis situation, to formulate questions and be able to prioritize specific situations so that when they're filling out advance directives, they can speak eloquently to things that they would or would not like, such as if I'm, diagnosed with a terminal illness, such as ALS or Alzheimer's or something to that extent, what are the particulars that they might like to see? I don't think a lot of people think about that when they're filling out their advance directives.
Yeah. So you're talking about having these conversations earlier and more broadly. So I'm going to speak from my role as a primary care clinician. But first, I want to say that the literature behind some of these documents, like a living will, like an advance directive, is becoming more conflicting. And I think what Steve tried to show in his piece was that even if a form is filled out, it may not help us make decisions when someone's in a different context. So in my role as a primary care clinician, I've tried to do healthcare agent for everybody. And then I have some information that I give to people who have some of those illnesses that I think a storm is coming. I don't know when, but we should be prepared for it. And I ask them a lot of the values questions. I actually have printed stuff through our EHR so that people can take those questions home, sit down with their healthcare agent, and start to process this stuff. If I do get sick, what really should I prioritize? I don't think we've had that spread out across our healthcare network or across our culture, but I would love to see that happen more often. But again, I think the important point is it's hard to make decisions without the context. Thank you.
One thing I will add, so Rebecca Story, who's a geriatrician out of UCSF, created prepareforyourcare.org. It is actually one that's about advanced care planning, but it's a really nice platform, and it's available in English and Spanish, and I think they started Cantonese and Mandarin. But they actually break down some of these, but they go to the what if space, just like how you mentioned. And so saying, what if you were diagnosed with a terminal condition? What if you no longer could speak and so there are those questions. What I find out the values mnemonic we taught, the place to go to the what if space to figure out what's important to someone is the limits question, because that can sort of say, okay, over there, if you're ever really sick or you're dying, what's important to you? With the caveats that people change their minds. And I remember my grandmother said I would never want to, have an amputation. I would never want an amputation. That's it. But when push came to shove and they said amputation or death, she's like, grandkids more important than my leg. I'm going to actually do that. And so just know that people do evolve, and that's the hard part with that. But I will say Rebecca's work is really lovely because it's geared towards patients, and they can actually think through some of those questions earlier and then report back to their clinicians.
We have time for one more question.
I love the way that you guys have presented, but my concern is for the client who is healthy and has not given any thought to how they want their family to act on their behalf. I think so many times clinicians talk to individuals and they make up plans and they write it down, but then they're not encouraged to share that with their families or discuss within their family who's comfortable with the role of being your advocate. I know in our family, we had some difficulties. I had a grandchild die last year, and it was up to the parents to decide whether to let him stay on a ventilator until he couldn't breathe anymore or to let him go. And there were many of us that had many feelings of what we would have chosen. But I think an ICN nurse, said it most eloquently. It's not about you. It's about what they have to live with. And so they were their son's representation. And even though I found it very difficult to watch my grandson die for 2 days, I had to understand that that was his little spokespeople, was my son and daughter-in-law. So in much the same way, if it were my parents, who would they have 3 children that they've raised feel comfortable with being their spokesperson, and would the other siblings respect that? So I think that all families should be encouraged to take that plan and then discuss it within their own family. Even though it's difficult between a doctor and patient, it's even more difficult with your loved ones.
The one comment that highlights is there was a study that was done about nearly 15 years ago, but it showed that 25% of healthcare agents knew they were healthcare agents, and 25% of them knew the wishes of their loved one. So that you can imagine, a lot of patients, their loved ones, when they speak for them, don't know what to say. And so we agree 100%. It's so important as the first step, identify who in your family would speak for you if you weren't able to, and then loop them in frequently.
I often suggest to schedule the conversation. So here's your healthcare agent form. Do you have someone in mind who might be able to help you with this? Would they be okay taking on this important role? And what do they know about you and what's important to you? Can they answer all these questions? If they can't, schedule a time. I want to talk to you about something really important. I want to offer you this role for me. Let's talk about it. Okay. Thank you, everybody. Thanks for inviting us.